So I'm going to talk about errors in the IVF lab, how KPIs, the key performance indicators, can be a savior. So not only the other service sectors and IVF Centre, which is also one of the service sector nowadays, we are worrying about quality, how to achieve a good quality. So how quality is defined? It's defined as the degree to which a set of inherent characteristics fulfills the requirements. So when it comes to an IVF center, we have several stages of treatment. So all of them can be presenting us a lot of inherent characteristics of an IVF center. So starting from stimulation, you go to ovum pickup, and before ovum pickup, the ovum pickup may be cancelled due to various reasons, including ovarian hyperstimulation syndrome. And then after all procedures are done, the OPU may be ending up with ET or not, or we freeze all the embryos. And if embryo transfer is done, then we go to the next stage where we see the patient is pregnant or not. And while we are doing the pickup, during the scanning, follicular tracking, we see how many number of follicles are there and how many number of oocytes are collected and how many of them are mature. And once we get the mature eggs, we go for either insemination by conventional IVF or injection by ICSI, where again, you have to see how many number of oocytes survive, particularly for ICSI. And followed by fertilization the next day, where again, you are going to look at the other characteristics such as whether the egg is normal, fertilized, or with more than 2 PNs. After fertilization, we go on to the next stage, which is cleavage of embryos. And again, we have to see how many number of these embryos are usable. And also with the blastocyst culture, you see how many number of blastocysts are obtained from these embryos and how many are usable. So when we look at the IVF Centre's lab, it has its own characteristics. So we are going to look at like fertilization rate, oocyte damage rate after ICSI, cleavage rate, blastulation rate, which is actually formation of blastocysts, and embryo utilization rate, where we get a number of usable embryos. And when it comes to frozen embryo transfers, we look at the survival of the embryos after freezing and thawing, or vitrification and warming. And we are going to look at also the cleavage rate, that is, if you culture these embryos, and how many blastocysts are obtained from them. And both are common to both of these fresh cycles as well as frozen embryo transfer cycles. We have a pregnancy rate, biochemical, clinical, implantation rate, and of course, cryopreservation rate for fresh cycles. So we should have these key performance indicators identified for these, particularly for these characteristics. So what are these key performance indicators? These are already set or prescribed indices to which characteristics are required to meet. And when you follow prescribed indices, you are already benchmarking your center. So how do you define these KPIs and how do you calculate them? To make our job easier, Ethiraj Special Interest Group of Embryology and the Alpha Scientists in Reproductive Medicine came together and they have prescribed some of the ART laboratory performance indicators in 2017. Right? To start with, we have some of the reference indicators. The first one comes to our calculation always is the proportion of oocytes recovered, where you calculate it with number of oocytes retrieved upon number of follicles who you expect on the day of trigger, and then percentage is your proportion of oocytes recovered. It is supposed to be 80 to 95% of the follicles measured. But here it might be a little bit different sometimes when it comes to the practice of the day. Many clinicians may not be scanning all the follicles. They might be scanning only those larger size follicles. In that case, then if you calculate this way of proportion of oocytes recovered, it may not give you a very accurate picture. Similarly, when you come to the proportion of M2 oocytes, the mature oocytes collected. So the Vienna consensus actually recommends to calculate it as a ratio of number of mature oocytes at ICSI upon the number of oocyte cumulus complex retrieved. So it is supposed to be 75 to 90%. So you can see that there is no proper fixed value here. There is a range given. And most of the time I have seen that the clinicians are not leaving the smaller follicles behind. They aspirate them also. And these follicles may not be scanned, or you don't have the scanned readings for this on your chart. So in such cases, your calculations may be slightly biased. So what do? I look at the follicular scan, and then I see how many number of mature follicles expected on the day of trigger. So then I count how many mature oocytes I have at the time of ICSI, then work out the ratio. So that's what I do in my lab. And the other performance indicators, actually, when you start doing the sperm preparation, also you have to look at the sperm motility post-preparation, either for IVF or IUI or even for ICSI. Anyways, this is not a greater index for ICSI. So you have to see how many progressively motile sperm are there, and upon all sperm counted, and calculate the percentage. So if you achieve 90% sperm motility post-preparation, you are actually competent. And you achieve more than 95%, you are setting a benchmark. You have met the benchmark actually. And when it comes to insemination and then the polyspermy, IVF polyspermy rate is supposed to be calculated as number of fertilized oocyte with more than 2 PN upon number of cumulus oocyte complex inseminated. So it is supposed to be less than 6% of the cases. And 1 PN rate for IVF and 1 PN rate of ICSI are also calculated in a similar way. And they are supposed to be less than 5% and less than 3%. Because with ICSI, the abnormal fertilization rate might be lower. So that's why the 1 PN rate is given here as a 3% or lesser than 3%. And of course, when it comes to the blastocyst development rate, you have to calculate it as number of good quality blastocysts on day 5 upon number of 2 PN oocytes on day 1. It's supposed to be 30% or more to achieve a competency value. Or if you achieve more than 40%, you are already setting the benchmark or meeting the benchmark value. But however, I'd like to do it in a different way for blastocyst development rate. Because sometimes, or not sometimes, many times we actually thaw the day 3 embryos and grow them to blastocysts in frozen embryo transfer cycles. So I'd like to calculate it as number of good quality blastocysts on day 5 upon number of embryos cultured. Then when it comes to the fertilization and insemination, particularly for ICSI, you have to look at how many oocytes survive. How many oocytes survive after ICSI? So how do you calculate it? Number of damaged or degenerated oocytes upon all oocytes injected. So if you achieve 10% or lower, you are competent, you are good. And if you achieve less than 5%, you are really excellent. Okay? You meet the benchmark. And when it comes to ICSI normal fertilization rate, we calculate it as number of oocytes with 2 PN. I don't want to focus on 2 PB because sometimes the PB can be fragmented and difficult to count. So I'd like to look at it as number of oocytes with 2 PN upon number of M2 oocytes injected. If you achieve 65% or more, then you are competent, right? You're good enough. And if you achieve more than 80%, you're excellent, right? So when it comes to IVF normal fertilization rate, it's the same way of calculation, but here it is number of cumulus oocyte complex inseminated. When it comes to failed fertilization rate for IVF, so it's recommended as less than 5% of the cases. I may recommend the same value for failed fertilization rate for ICSI also. And other performance indicators. After fertilization comes cleavage rate, number of cleaved embryos on day 2 upon number of 2 PN oocytes on day 1. So if you achieve more than 95%, you are very competent, and more than 99%, the benchmark is met, right? And when it comes to day 2 and day 2 and day 3 embryos, so you see that number of forces on day 2 or number of egg cells on day 3 upon number of normally fertilized oocytes. And if you achieve more than 45%, you are very good, or 70 or 80%, you are excellent. And the blastocyst rate, I have explained to you already. So my way of calculation is number of blastocysts formed upon number of embryos cultured to day 5. So similarly, the pregnancy rates, biochemical pregnancy rate, number of patients tested positive upon number of ET procedures done. And clinical pregnancies is number of pregnancies with fetal sac and upon number of transfers done. Implantation rate is number of embryos implanted upon number of embryos transferred. And live birth rate, number of pregnancies leading to live birth upon total pregnancies. So you can set your own benchmarking, right? So it's the same thing explained here. And I would say that sometimes, do you really need to look at the pregnancy rate as an outcome of laboratory? Because the pregnancy is controlled by a lot of other factors. In such, with that kind of condition, I think the pregnancy rate shouldn't be truly reflecting what's done in the lab. So you may be happy with how many usable embryos are produced. So how do you analyze these KPIs and how do you review them, right? So it's easy to adopt KPI prescribed by international or national standard if they are available, just like the ISHRAE and the Alpha Vienna consensus, or you can set your own. How do you set your own? Okay. You have to analyze your data from the previous year and look where are you, and then push yourself up from there. And you have to review periodically to adjust the KPI. So for example, last year, if you achieved, say, 70% fertilization rate for ICSI, and then you have to review and then make this year that 70% is your target to reach. And if you reach below 70%, you need to question why is it happening. And then this review should be done with important people, such as management people and your medical director, or whoever is responsible for the center. That's going to explain to you that why these KPIs are helpful to you. And moreover, all the embryologists have the same complaint that when the pregnancy rate drops immediately, the first question is to the lab, what did you do? But if you actually submit your KPIs regularly to your management or the medical director or whoever is in charge of the center, then they know from your KPIs that there's nothing wrong with the lab. So then how long to wait to analyze the KPIs? There are some KPIs which are immediate and some are delayed. So the immediate KPIs available are your fertilization rate. Every case, cleavage rate of every case, blastulation rate, survival rate after freezing and thawing. So when you see a fertilization drops or cleavage drops or blastulation drops for a particular case, immediately you have to analyze what are the other factors, like whether she's older or the embryos are good quality, or did you change something in the lab recently? So things like that. And delayed KPIs are pregnancy rate and live birth rate. So you need to wait until the pregnancy is established or when the baby is born. So immediate KPIs usually help us to see whether we are on the right track, right? So as I said, the regular analysis and submission should be done to your clinician or the management, just to assure the quality. And you can do the analysis case by case, weekly, monthly, annually, chart them. So this is a live example from my center for this year. And you can see the fertilization rate is given for ICSI for every month until August. So you can see that some months, actually, they are a bit down. If you look at the graph here, the upper limit and lower limit are established from last year's data, and the green line shows what is happening this year. So most of the time, we are actually all right. But if you see in April, the fertilization dropped to 72%. So what's happening then? So when I analyzed, I came to know that actually that's the COVID lockdown started in Singapore, and Ministry of Health was restricting the IVF centers not to treat everybody, only those who are desperate and those who are older, which means that delaying the treatment should not affect their pregnancy chances. And so again, ICSI lysis rate, you can see that overall I achieved a good lysis rate, less than 10%. And establishing from 2019, we are not bad. almost the same. And you look at the graph, you can see that it has increased again in April. So again, it is related to those patients, like all the patients who came into the clinic. Also, you can see the number of eggs injected are not much during this time. So failed fertilization rate for ICSI in 2020, what happened? So we had only 2 out of 200 cases, which is 1%, so doing very well. But what happened in May? So I marked it as red. So the failed fet rate in March has gone up. But if you look at it, it's only one case. So what is the denominator? Number done, 15, right? So whereas in August, also I had one case with failed FERT, but out of 31. So your denominator also makes things to fluctuate. So that's how you have to troubleshoot. And when I look at these two cases, they're actually given as only 1 egg each. So whenever you recover 1 or 2 eggs, there is a high chance of failed fertilization. When it comes to frozen embryo transfer cycles, also we look at the survival rate after vitrification and warming. So achieving around a 97% survival rate, which is good. And compared with last year's mean, I think we are slightly better. And looking at the graph, you can see that we are doing well, right? Overall, everywhere is fine. And when it comes to cleavage rate of those embryos which are thawed and cultured to either day 3 or day 4 or day 5, so we see that 92% of them are cleaving further. So it's roughly about the same as the last year. But in March, again, we dropped, right? So you can see in March, it dropped to nearly 85%, which is not acceptable in our standard, right? So when we troubleshoot, again, we saw that these are those patients who are desperate, who came back for their FETs, and they are usually very old patients, and their embryos are not good ones. So if you analyze your KPIs like this, right, you can actually troubleshoot much better, and you can find an answer what's happening. Supposing something goes wrong, you see that the values are not as you expected, then you start to troubleshoot what happened. First, you start with the lab. What happened in the lab? So go and look at anything changed, any consumable changed, or any new staff has joined, so things like that. And later, you slowly spread this, and then your analysis should extend to the clinical side, where what kind of drugs, which batch was used, what's the average age of patients, and what kind of patients you treated during this time, right? And KPIs can also be used and applied in different ways. So this paper, published in 2017, shows that this particular center has developed a KPI score, where if the age is less than 36, the patient gets 5 points, right? And AMH more than 2 get points, so another 5 points. So like that, they have given 5 points for all the good prognosis, and 3 points for the mediocre cases, and the poor diagnosis will get 1 point each. So based on that, they get a KPI score combined for age, AMH, number of oocytes, mature oocytes particularly, and fertilization rate, and embryo morphology quality. And when they did the study and tabled it up, you can see that there's a 70% probability for a clinical pregnancy when the KPI total score is 25. Of course, the confidence interval is also given. So when the KPI score is 5, the pregnancy chances are very low, right? So this way, you can develop your own system to use KPIs. And also, you can track quality. Can embryology key performance indicators be used to identify clinically relevant shifts in pregnancy rate? Yes, they did. So like the charts I showed you for my center, the Stewart control chart of monthly day 5 blastocyst utilization rate for almost 1 year is shown here, right? So the blastocyst rate dropped here. Then you start to troubleshoot what's happening there, right? And sometimes KPIs are even prescribed by the regulators. such as the bodies which control the licensing of IVF centers. So this center in Switzerland, actually, the Quality for Assisted Reproductive Technology in Switzerland has recommended these KPIs in their regulatory guideline. So following these guidelines is also very helpful, and see whether you are up to the mark in your nation itself. So what are the benefits of doing all these things? Of course, you can check your performance and to maintain the standard that is promised to our patients and clinicians, and also to troubleshoot when your performance drops below a certain level. And this one will help you also to benchmark against national or international standards to see how you fare with all other people, right? Of course, I don't need to say this, this assures quality. Okay. So to summarize, setting KPI helps to benchmark an IVF center, and also easy to troubleshoot. You can actually identify problems so that you can maintain the standard of the center, right? You may set your own KPIs, or you can follow those which are prescribed, like those I described in my slides. And if you follow your own KPI, then it should be reviewed periodically. You can't stick to the same KPI value every year. For example, when you start your center, you might be targeting at 60% fertilization rate for ICSI. But next year, you should change if you improve, right? So that's the way it has to go. So with this, I thank all of you.